Health Economic Evaluation. Professor Toomey invites you to a lecture. But first things first, is it worth for you even to start watching? This will cost you around 5 minutes of your time, which you could spend on something else. However, you can get benefits too, as it might be fun, useful, and something you can share with others. Considering the relatively low cost and high potential benefits, you will probably choose to watch this movie. Great, you have just made a consumer choice. We will talk further about how consumers make choices in a minute. But let's start with a general definition of economics. Economics is a social science that studies how individuals, businesses, governments, and nations allocate finite resources. The time you have is an example of scarce resource, and you have just decided to spend some of it on watching this video. You have made an informed choice after considering related costs and expected outcomes. In the world as seen by economists, there are consumers and producers, and some kinds of goods between them. Consumers choose to acquire goods which provide them greatest satisfaction. In economics, we say that consumers have an objective to maximize their utility. Producers produce and distribute goods with an objective to maximize profits. Free market assumes fully informed consumers, and producers trade goods without restrictions and third parties involved. A free market reaches over time an equilibrium, a state in which supply and demand are equal and neither prices nor quantities show any tendency to change. In other words, free market equilibrium guarantees an optimal use of limited resources. So, is healthcare an economic good like others? At first sight, in the healthcare sector, we also have consumers, producers, and supplied goods. But could healthcare resources be allocated according to free market rules? In practice, the situation in healthcare is much more complicated. Patients are the consumers of healthcare, and they have an objective to maximize their health. However, patients do not directly choose and acquire goods. Physicians may decide of the treatments they take. Moreover, in most of the West world, neither patients nor doctors pay directly for treatments. All or the largest part of the costs is paid by public payers or insurance companies. Patients or doctors generally don't consider the full opportunity cost of a healthcare good when choosing to consume it. There are other unique features of the health economics. Influence of non-market institutions. Incomplete information and restrictions and regulations. For all these reasons, trading healthcare on a free market would not lead to an optimal allocation of healthcare resources. Instead, in order to decide how best to use and distribute healthcare resources, payers rely on health economic evaluations. Healthcare decisions most often concern the choice between different interventions which vary in cost but also in terms of efficacy and safety. Health economic evaluation compares interventions in terms of their costs and outcomes. There are 4 main types of health economic evaluation: cost minimization, cost benefit, cost effectiveness, and cost utility analysis. They differ in the health outcomes taken into account. Cost minimization is performed under assumption that compared interventions are equivalent in terms of their efficacy and safety. This assumption leaves outcomes out of the consideration and only costs matter in choosing between the interventions. The one with lower cost is preferred. Such situation is not so often encountered in practice, therefore cost minimization analysis is rarely useful. At the other end of the spectrum of health economic evaluation approaches, there is cost-benefit analysis. This type of evaluation requires expressing the value of all health outcomes in monetary units. Due to the challenges of assigning monetary values to health outcomes, cost-benefit analysis is rarely conducted in practice. In cost-effectiveness analysis, outcomes are measured in so-called natural units, which are disease-specific or more general. The primary indicator produced by a cost-effectiveness analysis is the incremental cost-effectiveness ratio. The ICER represents the incremental cost associated with the use of the treatment strategy under evaluation, usually compared to the current standard of care per unit of health outcome gained. The outcome should be unidimensional information of the benefit of the drug to allow arithmetic operations, for example, number of avoided hospitalizations or relapses, number of patients with treatment response, and number of months of life extension. To perform a cost-effectiveness analysis for a new drug, at first costs and outcomes need to be estimated separately for the new drug and comparator. The cost is expressed in monetary unit. In the next step, the difference in costs and the difference in outcomes between the drug and comparator are calculated. The ICER represents the cost per unit of additional outcome gained with the new drug over the comparator. Cost-effectiveness analysis may be informative when a choice is to be made between two interventions for one condition where a single unidimensional health outcome is relevant. But there are often multiple health outcomes to consider. It may be difficult for a given condition to aggregate favorable and unfavorable consequences of treatment in a single unidimensional outcome. Moreover, due to healthcare budget constraints, reimbursing a new treatment in a given therapeutic areas leads to spend resources that would otherwise be potentially allocated for other disease area with different types of health outcomes. This kind of decision requires a specific type of economic evaluation called cost-utility analysis, which is using unidimensional outcome that is universal and can be used across diseases. In cost-utility analysis, all outcomes are expressed in a single universal unit called QALY. If you want to get to know a bit more about QALYs, watch our previous video on the topic. The ICER obtained from the cost-utility analysis represents the incremental cost of an additional QALY gained. The threshold value differs between countries and is often not clearly defined. Furthermore, the threshold may be modified by factors such as the prevalence, severity, and unmet needs associated with the considered disease. For example, in England, a threshold of £20,000 per QALY is set and can be increased to £30,000 per QALY upon some considerations. Moreover, technologies with an ICER up to £50,000 per QALY could still be recommended if they are associated with life-extending treatments as part of end-of-life care. In the USA, there is no official threshold, but a value of $50,000 per QALY has been frequently referred and used in many cost-effectiveness analyses historically. More recently, the values of $100,000 to $150,000 per QALY have been used in publications. Let's consider an example of 5 treatments to be compared for a given condition. Each of the treatments is related with a certain cost and benefit expressed in QALY gained in 1-year time horizon. These treatments can be presented graphically on so-called cost-effectiveness plane. Most often, instead of presenting absolute costs and QALYs for all treatments, a reference is chosen. The cost-effectiveness plane is determined by differences in costs and QALYs versus reference treatment. Depending on location on the plane, we can characterize 4 different types of interventions in relation to the reference. Threshold can be represented on the cost-effectiveness plane by a line crossing its center. Watching this video, you have learned why health economic evaluation is needed, how economic evaluation can be performed, and how the results of economic evaluation can be interpreted. In practice, economic evaluation requires health economic modeling. Stay tuned and watch our next video on modeling. In the meantime, you can learn more about QALYs in our previous video on the topic. And don't forget, you can increase the cost effectiveness of this video by sharing it with your network.